A very good evening to one and all. I am Arpita from the IGCP group. Welcomes you all to the session on the topic Management of Acute Coronary Syndrome. So in this session, we have with us Dr. Amamukti Bingi sir, who will be discussing with you key aspects including risk satisfaction, the early diagnosis, pharmacological and interventional treatments, and post-ACS care. So, without any further delay, I would like to introduce sir to everyone. Sir has done MBBS, MD in medicine, DM in cardiology. He's an interventional cardiologist at the Bingi's Heart Care and Fertility Center, Bangalore. So, with this very brief introduction of sir, now I would request him to please go ahead with the session. Over to you, sir.
Thank you very much. Sorry for the delay, that whatever that happened because of that linking problem. I have to start with the share now.
Yes, sir, kindly go ahead.
Okay. Slide only now.
Yes, sir.
Is it okay? Weaving is okay?
No, sir, kindly see your slides.
Okay. What that inspector I have to write, or what? What is the thing like?
Sir,
I have the slides already on there.
sir, have you clicked on share screen option?
The slides are there.
Sir, have you clicked on the share screen option?
Share screen, I did already do that.
Okay,
Okay, 1 minute. I will do it again.
sir, do it again. Yes, sir.
Share screen.
Yes, sir. Then, so kindly click on the presentation that you would like to share.
Okay.
Sir, have you clicked on share? It's not showing. Yeah. Now it's not.
Now it is saying. Okay.
Yeah,
How,
sir, make it a full screen.
how do I make it full weaving?
Sir, kindly zoom it, sir.
Okay, it's okay. Only to slide only.
Yes, sir. Slide on. Slide on. So, can you click on the zoom options left corner? 75% I can see. You can make it a bigger one. Left corner.
Ankita, you better come down to Bangalore once sometime and teach me all these things.
No, sir, no problem. Yeah, you can go ahead now.
Okay, it's okay now. You're able to see?
Yes, sir, yes, sir.
Okay, let us, without having much ado, let us go ahead and discuss a very important topic of this so-called acute coronary syndrome. You know, the management of acute coronary syndrome is a very important entity, and here the focus should be more on both the diagnosis and as well as the management together. Basically, it is a spectrum. Now, earlier days, we used to classify them as acute myocardial infarctions, unstable, and the like. But now we have put it into a single basket. We call it as acute coronary syndrome. It is a spectrum, in fact. It comprises of common pathophysiological principles. There is an atherothrombotic process. They do respond with the antithrombotic and anticoagulants, whether you take an MI setup or an unstable angina setup, all of them have the same thing. And equally, they have the question of urgency, there's a question of also a sudden death possible in any of these entities. That is why they have been grouped under one, the acute coronary syndrome. Fundamental to all of these things is basically the atherosclerotic process. In the atherosclerotic process, there are some plagues which have been recognized by various IVA studies and coronary endoscopic studies, that there are so-called vulnerable plagues. They have some special characteristics because of the hydrodynamic forces as well as the neurohumoral mechanisms that are capable of rupturing at the shoulder levels, which leads on to platelet and coagulation deposition, what we call as a thrombosis. And this is not as it appears to be, it's as simple as it is, but we have recognized that particular areas, there is some endothelial dysfunction, which itself makes the coronary spasm. Small emboli also do take place, artery to artery emboli from the lesions. And these are all the various gametes of the unstable angina. This is a picture to show you how the unstable angina looks and how the acute coronary syndrome goes on becoming a myocardial infarction. The main difference appears to be in an unstable angina, the clotting process is not completely occluded. In an the so-called non-STEMI or in the subendocardial MI, which used to call them earlier, there is a partial obstruction. Whereas in the STEMI, there is a total obstruction. This is the gradations as far as the occlusion of clot is concerned. And as you see here, there is an unstable angina, NSTEMI we call them as. Earlier terminologies have all gone off now. We use as simple words as a STEMI. And accordingly, we do divide them as anterior STEMI, inferior STEMI, posterior STEMI, and the like. And of course, sudden cardiac death is also a manifestation. But we don't have much effort to see some of these sudden deaths that happen in the home or in the office. But autopsy studies have all revealed the same pathophysiological principles. It itself is a very big topic. I'm not going to highlight on that. As I said in the beginning, these are all acute events. There is a very urgency in the management. The risk of sudden death is there. Equally, along with that, there is a risk of recurrence. This is a very important thing. We have many patients do come to me and ask me unstable angina, myocardial infarctions, and that like. They do get discharged by the third week, second or third weeks, sometimes within 1 month. To develop one more heart attack is quite high. So recurrence is a very important characteristics of these acute coronary syndromes. As I made in passing remark, the evaluation and treatment of these acute coronary syndrome should go hand in hand. No, I will wait and do the test and then make a diagnosis and then treat. Nothing like that. You should be treating as you are getting the blood test done or doing an oxygen supplementation to the patient and the like. The clinical presentation of acute coronary syndrome, as in any chronic coronary syndrome, is basically angina pectoris. The angina pectoris is earlier Diamond Forrester's classification wise. We have a typical angina where there is a retrosternal component. It is like a pressure-like sensation coming by an effort under rest sometimes. Most of the acute coronary syndromes do come with a minimal activity under rest, relieved after a particular time. So other than this, if you find a chest pain coming in the precordial area, the shoulder area, only the arm area, they probably constitute the so-called atypical anginas. This terminology of atypical anginas is going on to the lot of controversy because this makes you people to think may not be such a gravity of the situation and hence it should be removed, something like that. But anyway, for our practical purposes, it appears to be a very important terminology. Typical angina, atypical angina. And we have a non-anginal type of pain. The non-anginal pain doesn't come in acute coronary syndrome. This is one of the chest pain evaluation entities like chest wall pain, acidity pain, and psychiatric pains, referral radicular pains, and the like. The angina equivalents are most important. A matured cardiologist will be able to recognize not only the chest pain as an important presentation, but there are a lot of patients, elderly, women, and those who have hypertension and diabetes. They are capable of producing symptoms which are not typical of a pain like. They may say, "Sir, I am getting extreme exhaustion, a fatigue." They may say that I am feeling little giddy when I start walking. Or they may say that they say I have a disproportionate sweating. So these are all called as non-anginal symptoms. An astute physician should keep them in the mind in the background of the age of the patient and the other associated risk factors and make a diagnosis. Of course, we have an angina equivalence also. Angina equivalence, as I said in the beginning, same, this fatigue and other thing. Apart from the angina equivalents, we have some remote anginas. The chest pain may come into any area. If you have heard of the so-called Bezock principle, where the radicular pain often gets distributed to the same nerve pole, like that, you can have pain coming from gallbladder pain may resemble anginal pain can come into the gallbladder area, something like that. These are all remote anginas. And of course, silent ischemia itself is a very important entity. So any of these manifestations can be present in acute coronary syndrome. Most important, the diagnostic point of view is the character of the pain. It is an diffuse retrosternal or a precardial pain. Patient cannot pinpoint it, and it appears to be like a heavy or some sort of a burning type of a pain. This is a very characteristics of anginal pain. This differentiates the anginal pain from other pains also. And in an acute coronary syndrome, we should give focus to the accompanying symptoms. Some patients may say, "Sir, I not only feel pain, I feel as if I have to take hard breathing." There is a sense of breathlessness because of the elevated end diastolic pressures and a little pulmonary congestion. They may feel breathlessness, and they may also have excessive autonomic phenomena. You have seen many cases of myocardial infarction which walk into the casualty. They will be sweating a lot, their hands will be very cold, and they will be having many more autonomic phenomena like nauseation, vomiting, even sometimes diarrhea. So these sort of phenomena should clinch a diagnosis. You may be dealing with an acute coronary syndrome. And of course, everybody knows, physicians all know that there is an anger anemia manifestation, Levin sign, they're all well-known phenomena. And in my opinion, a pain which is not very severe, which is little bit of a more of a typical variety, we should give focus to the age of the patient, his underlying blood pressure, sugar, and other manifestation, past history by HD. Sometimes this particular pain may be an acute coronary syndrome rather than a non-cardiac chest pain. So we should not neglect that way also. Now, anginal pain duration wise, we have a rough classification. Angina, in fact, is a transient ischemia. The pain doesn't last for more than 3 to 5 minutes. We have slowly, over a period of time, recognized that the anginal pain can remain for a longer time, up to 10 minutes or 15 minutes. Some of the authorities have defined this as prolonged angina. The pain can go up to 10 minutes. If the pain is remaining for more than 20 minutes, it is to be considered as a acute myocardial infarction until proved otherwise by various other investigations. These are all rough approximation as far as the times are concerned. Examination of a cardiac patient when he comes with an acute coronary syndrome, it is not so much helpful for you. It will not be giving you any specific signs or any specific sensitive signs. We know that there is a tachycardia, there may be some amount of a narrow pulse pressure, there may be an precardial pulsation, an S4 thing there, maybe a murmur. So many things we do say, but none of these signs do say that this particular patient, this particular sign is suggestive of an acute coronary syndrome. So most important is when you examine the patient, you should examine to see that you exclude other conditions. I'm going to make a comment, which are the other exclude conditions which mimic an acute myocardial infarction, which they're as bad as acute myocardial infarction. The element of sudden death is there. Those entities should be kept in mind. We should examine the patient thoroughly, like palpating the pulses, peripheral pulses, examining for the hypertension, examining for the heart failure, examining for the pericardial rub, and the like. Of course, it is also helpful in recognizing the various complications. I was trying to make you the deadly combinations of an acute, along with acute coronary syndrome, which produce a sudden death in the casualty or in the ICU in the ward. They are the aortic aneurysm, that is the ascending aortic aneurysm dissections, pulmonary embolism, pericarditis with a tamponade, pneumothorax. The earlier literature often says about even an esophageal rupture also producing a drastic mediastinitis, mediastinal air accumulation, and even the subcutaneous emphysema formation and all that. But these are the four ones are the most important one. How do you make a diagnosis? As I said, the examination and investigation should be going hand in hand with the treatment. The first and foremost investigation, all the scientific bodies have recommended that you should take an ECG. ECG has to obtain in about 8 to 10 minutes of the patient arrival. That constitutes a good quality service the hospital is giving. And this presentation, remember, in up to 5 to 10% of the cases, it may be normal. So if you think clinically that the patient has got an acute coronary syndrome, kindly repeat it after about 30 minutes or even after about 6 hours. And there is nothing like comparing that ECG with the previous ECG if the patient is carrying. So this is one of the picture where it shows that there is an ST depressions and ST elevations and a tall T waves and tall T inversions. You see in that green panel here, then there is an ST elevation suggesting of an anterior myocardial infarction. These are the very classical picture patterns we can recognize in the ECG. The second important investigation that we do is the cardiac enzymes. Cardiac enzymes had their ups and downs. We were doing earlier so-called CPK, CPK-MB. We were doing LDH ratios and many more, even myoglobin and all that. But now we have coned down and every laboratory is doing what is called as a high sensitive C-reactive protein. In short, it is known as HSCRP. It is then each laboratory has got roughly an cutoff point. It should be less than 0 to 17. Above 17 is considered suggestive of myocardial injury. And unlike any test which comes into the it carries its own disadvantages. Myocardial ischemia should produce an elevated high sensitive C-reactive protein. If there is just an injury in the form of a stretch of a myocardium, like in a heart failure, carditis, post-resuscitation, even sometimes we have observed in sex parity wise and also renal failure, high sensitive C-reactive protein may be elevated. We have detected and marginalized one syndrome called as acute coronary injury syndrome without having an coronary artery disease in some of these patients. This is a very big aspect of it, which I'm not going to talk about it. Many a times, by the time the patient lands up to the hospital, it may be 2 to 3 hours of the chest pain onset, you will have troponin positivity. And in a case of an acute coronary syndrome, if you are suspecting, but first test is negative, and clinically you feel there is a strong possibility is there, kindly repeat at the end of 3 hours. Even if at the end of the 3 hours it is normal, that means you are not dealing with an acute coronary syndrome. But otherwise, those who are getting hospitalized or admitted, we usually repeat the test by about another 8 to 12 hours. The rate of rise and a rise and a fall pattern is a more important thing than a very just a value, a simple cutoff value. There are some sensitive laboratories. There are some, academic laboratories. They also do pro-BNP in every case. There are some inflammatory markers are also being done. that they are all beyond the scope of an average practicing cardiologist. In a patient, when it lands up, first thing, other thing that we have to do is hematological investigation, including a platelet count. We have to do biochemical blood tests like blood gases, blood sugar, blood urea, creatinine, so that we can see what the next thing can happen. Serological tests have become a more or less normality because we can think of taking up the patient for cath lab. We have to do an HbA1c, HIV, and other tests. X-ray chest is not being done so frequently. Echocardiogram is also not available everywhere. But these two tests, you should keep it in mind. So there are some points like whether the patient should be hospitalized. If he's hospitalized, the ICU is there, non-ICU is there, the ward. I don't want to highlight on that. You admit the patient the moment you see the casualty, make the patient comfortable. The anxiety associated pain often increases sympathetic activity. So you make the patient to give a pillow, cover him up with a blanket, make him comfortable, assure him everything is going to be all right. We are here to take care of you. That often helps in the cutting down of the sympathetic overactivity. And of course, you should may have to do the sedation, but many of the centers are not using. Mild sedation will cut down the sympathetic activity. Earlier, we used to use left and right IV morphine in the management of myocardial infarction. We are not using it anymore. No pethidine, no morphine. We are using it only in some cases of acute pulmonary edema with myocardial infarction, and those who are needing intubations, we try to use IV morphine. Because there are studies which have shown that IV morphine may have more disadvantages than advantages. Most important thing is we should give the patient one normal saline or dextrosaline lifeline. Many a times in the process of putting a monitor and oxygen and the like, we forget simple things because that acts as a lifeline where you can give an emergency drugs to the patient. So please kindly mate, oh, patient is just florid pulmonary edema. Why you want to give normal saline? A patient is a diabetic. Why you want to give an dextrosaline? This sort of questions are always there in the rounds, but this is a very important route by which you can give emergency drugs. Kindly keep it. You keep it in a maintenance line. And it doesn't mean that you should be giving at the rate of 60 or 100 ml per hour. You keep it about 25 to 30 ml per hour to keep the IV line open. And of course, you should be able to do the continuous ECG monitoring, non-invasive hemodynamic monitoring, routine laboratory tests, all should be done. All these patients, to give oxygen or not oxygen is a very tricky question. Nowadays, what we are asking is our nurses or the junior doctors, they should examine by pulse oximetry oxygen level, and then they should try around 19, 85, 90, like that. They should start using oxygen. But there are some other authorities, you try to give the oxygen because the diffuse oxygen also helps in the coronary circulation oxygen level and the like. You can keep it around 3 liters per minute, either by the nasal prongs, and you can go on adjusting depending upon the level and the comfort zone of the patient. The most important is you have to load the patient with the drugs. These drugs include, there are 4 categories. One is the antiplatelet drug, that is an aspirin. When you are talking about aspirin, you use a soluble aspirin, please. Don't use an entry-coated aspirin. Don't ask the patient to swallow it. You better make the patient to chew it and then take a small sip of water. And the dose is usually 150 to 325, whatever it is. In the pharmaceutical industry, usually 325 disperin is available. You can give that. And you can also give ticagrelor, prasugrel, clopidogrel. Earlier days, we were using more clopidogrel. But those of us who are interested to do more and more PCI within the span of about 15 to 20 minutes, rapid antiplatelet action is provided more by ticagrelor. Okay, but the ticagrelor can be loaded. BT dose later on subsequent course. Prasugrel has come down. Clopidogrel is being some centers being used as an alternative, and they should also be loaded with a high dose statin. High dose statin equivalent to an 80 milligram of atorvastatin or a 40 milligram of rosuvastatin, because it has been found. You may say that, will this around 1 o'clock or so, we have given that, and he is going on with an MI. By 6 o'clock, his cholesterol will come down. It is not the cholesterol effect. It is then and what is called as an anti-inflammatory action that these drugs are having, and they have got also stabilizing action on the unstable plaques. That is why we should give them. And of course, some of the places we give injection IV heparin 5,000 units load with, but to kindly mention it, some hospitals, if it is not an acute myocardial infarction, they give low molecular heparin. You be familiar with any one of the two, three, enoxaparin or dalteparin or whatever it is you are giving. Okay, for example, enoxaparin you are giving, the usual recommended dose is about 1.5 milligram per kg body weight. But in the casualty, if you have given, say, like 40 milligram, kindly mention it, because I may have to adjust the heparin dose accordingly on the cath lab. And get prepared for the patient. If you have got facility to do the cath, get prepared. That itself is a big process. In my experience, loading him with aspirin or loading with a Pantodec or whatever it is, or a statin is not an important. It takes hardly 2 minutes or 3 minutes. But to call the relatives, get the consent, get the finance clearance, inform the cath lab, talk to the interventionist, or you yourself with an intervention, going there and changing the address. And these are things which take some time. So this time should not be lost, because we have seen the best benefit for an acute myocardial infarction, whether it's a thrombolytic therapy or a PCI, is around 3 hours. So we have extended it up to 6 hours. For PCI, some cases, the ongoing chest pain, even of 12 hours. But this is as early as possible without wasting the time. You take up the case, it is better. So consent, finance, cath lab information, transport, preparation for the path lab, for the cath lab. We usually, earlier days, we used to do the femoral approach. So we used to shave both the femoral areas. And nowadays we do more and more radial, but still, if there is a failed radial, I may have to do through the femoral. They have to shave that also. And I need not to go into the various other aspects. And STEMI management are only two. One is either you use a thrombolysis. Of course, you have used all these adjuvant medications, or you are doing an angioplasty. Diagnosis is easy by ST elevation. ECG is the test which is going to help you and tell this patient is going through an acute coronary syndrome and the so-called myocardial infarction subset. You have to do either thrombolysis or you have to do either PCI. If you try to be a cardiologist who's concerned about the whole population of the world, in all the places, still the thrombolysis is being followed, because they're not having enough resources to have cath lab in every place. So wherever the cath lab is there, we are trying to do the cath procedure. That is called as the primary PCI. There are recognition as far as this is concerned. There are difficulties with left bundle branch block, the so-called bifasicular blocks, previous MIs, posterior MIs locations. I'm not going to deal with all these things. So in acute MI, first thing is you make out whether he's stable or unstable. If it is unstable, go for a direct PCI. If the lesions are suitable, as the patient has got hemodynamically stable, is a large anterior wall ligament, again, go for a PCI possibly. Small and medium size, either direct PCI or thrombolytic therapy, whichever it is. But it all depends upon the facility that is available. Let us move on to the other category, the so-called STEMI. No, there is no ST elevation MI. By that connotation, that means in the ECG, there are some subtle ST depressions and or T wave inversions. And that is how you make a diagnosis of NSTEMI. And NSTEMI cases, they do not go for a thrombolysis. They can either go for medical treatment and or the further on PCI and or surgery. Remember, I would like to make a small comment for all the junior level cardiologists here. In an acute coronary syndrome, it is just a basket diagnosis. Initial diagnosis is acute coronary syndrome, probable acute coronary syndrome. And the subcategories evolve over time. And the final diagnosis is available only at the time of discharge. And here there has been a very great advance that we have taken. For example, a patient has come with a chest pain. We say acute coronary syndrome, NSTEMI. Then you say low category or high category. Troponin is positive, troponin negative. LV function is good, null function is not good. Facilities available, you have done an angio, three vessel disease, no three vessel disease, or two vessel disease. Like that, you can go on categorizing, subcategorizing, and communicating. This is a very important thing for communication with the other cardiologist. Clinically, in unstable angina, we have rest angina, recent angina, progressive angina. Everybody knows about it. It started with the gauges, so-called gauges classification. Now we are using more and more what is called the Braunwald's classification. Braunwald's classification, if you go on reading, it looks as if it is a little complicated, but it's a very easy. Well, first category and foremost category is the so-called secondary anginas. The subsequent categories are also called primary anginas. And we are, over a period of time, as matured cardiologists, we have recognized there are some subsets like post-MI angina, post-CABG angina, post-PC angina. They're also grouped under the unstable category. I am not going again into this thing. Here also we have got a stratification, but earlier we used to go more by Kilip classification and try to divide them and take up the. A mature cardiologist will be able to recognize a sick patient from a non-sick patient, and he will be able to calculate by looking at the age and the lungs and other things to make out whether the patient is really a high risk case. The extent of ischemia, infarction, electrical instability, LV dysfunction, coronary, these are the four fundamental things which determine the prognosis in acute coronary syndrome. Every effort should be made to recognize the extent of these things and managing these things. In acute coronary syndrome, we have recognized, apart from the clinical features, something like severe ST depression, multiple lead ST depressions. We have recognized special syndromes in ECG winter sign, while the others Wellens sign, not Wellens sign. ST depression with a subtle ST elevation, other leads, for example, inferior leads, you may not see at all an ST elevation. You may see some amount of very significant ST depressions in the anterior leads. Posterior wall MI is very difficult to recognize also. ST depression in the AVR and in ST elevation in AVR with a lots significant ST depression in the anterior leads. It is in almost making a diagnosis for a left main stenosis. And of course, ejection fraction less than that, multiple wall motion abnormalities in echo. Echo is not available in every center immediately to do in the casualty or in the cath, unless we feel that the patient is deteriorating or not doing well after a PCI, we try to ask for an echo machine. So, as I said, ECG is a very important thing to decide thrombolysis. It also characterizes high-risk cases. And more than that, as I said, the changes that have taken place over a period of years are that the antiplatelet drugs, which when we started with a large dose of aspirin, it has become a small dose. We are going more and more for the drugs like ticagrelor than the clopidogrel. We are using more and more high dose statins to everybody. And of course, we are not doing any more that so-called Swan-Ganz monitoring other thing. There is a more of the time there is an indirect monitoring being done. And prophylactic lidocaine is not at all being used. Earlier, it was to be a very common thing in acute myocardial infarction. Similarly, IV beta blockers are also being questioned. And of course, we have to use the ACE drugs, but the ACE drugs, ACE inhibitors, their usage is depends upon the cardiologist. We all know that acute myocardial infarction, first 24 to 48 hours, so the hemodynamics are continuously changing. Okay, if you are trying to monitor by the recognition of the blood pressure change or heart rate, you may be doing injustice if you use an ACE inhibitor. That is why you should use an easily recognizable ACE inhibitors like an enalapril, a small dose, titrating dose, check the PP pressure again and again use it. Most of us, we use it by the end of 24 to 48 hours. And of course, the existing cardiac enzyme elevations are high, and renal dysfunction is there, liver dysfunction is there, GI tract healed peptic ulcer is there. Examination itself shows there is an acidosis, electrolyte disturbances, diabetes is there. These come under the so-called high risk category. They're easy to recognize. Clinical characteristics are, of course, age and other things. Okay, then scoring systems are there also in this unstable angina. Be familiar with them. As I make out, just looking at the age factor, looking at the face of the patient, how he is sick, the ongoing chest pain is there or not, what is the systolic blood pressure coming somewhere around 90 or 100, is any heart rate which is more than 100, any previous MI is there, whether he has been already taking an aspirin, a known case of IHD, whether the previous LV dysfunction is there. At examination, either heart failure is there or shock state is there, or frequent PVCs are there, tachycardia is there, or any of the new cardiac murmurs are there. They all constitute an significant risk factors. CAG has emerged in a very big way, and angiogram is a very important test. It not only gives you the anatomy, it tells you the diagnosis, it also tells you the extent of coronary heart disease, which may add to the prognostic factor. We can recognize left main disease, three vessel diseases, chronic total occlusions, diffuse diseases, tandem lesions, small caliber vessels, poor runoff, poor distal target, all of them can be recognized to make a proper decision making in the treatment. Should we do CAG in every case? I feel it's my opinion, it should be done. The literature is divided about this conservative treatment versus an aggressive CAG treatment, PCI treatment. There is no difference in mortality and other things. But, if the facilities are available, it is better we do in every case of unstable angina. Early angio is better. Procedure has become, I'm audible that side. Procedure has become very simpler and safer. Procedure has become very simpler and safer. We can recognize left main disease in about 10% of the cases. In 10% of the cases, there are no lesions at all. In 30%, you may find three vessel disease, equal number, two vessel disease. You can also recognize some other phenomena without any obstructions, like slow flow phenomena, recanalized vessel, very minimal lesions, coronary spasm, bridging coronaries. So which do not need an intervention like putting in a stent there. Adjuvant drugs I have spoken about, beta blockers, anti-anxiety drugs, statins, lidocaine, ACE inhibitors, cardamom, so many things we are using. Beta blockers per se has come into controversy. Oral versus IV, I am not going to highlight it, but they are very good drugs. In my opinion, they do reduce ischemia, they do reduce the threshold, they do change the threshold for ventricular fibrillation and sudden arrhythmic deaths. We are using less and less of anti-anxiety drugs. The various scientific bodies are not talking about it, but we have seen a lot of patients having anxiety features and not able to sleep in the night time. We should be able to use them. And IV lidocaine has come into less use, and ACE inhibitors and R drugs I have already told you. There are many more. See, nowadays the patients do not come in an isolated packet of acute coronary syndrome. They have many more problems. They're 60s and 70 years of age. They have uh, no lung disease, renal disease, and so many other things. And we should keep those points in mind. And in any case, whether it is an unstable angina or acute myocardial infarction, we should be watching for the progressive development of mechanical complications, recurrent ischemia, sudden death in spite of you taking care fully. I've done a wonderful angioplasty, patient dies later. Thrombolysis you have done, again he dies and goes to the bathroom, he collapses. This element is there first 7 days to sometimes even up to 1 month time. LV dysfunction, heart failure is an residue that often happens. It adds to the large number of heart failure patients. VTAC and arrhythmias and ICU syndrome, depressions, we are not giving so much of a thought, but they are really burning issues. And the changes that have happened is as far as the ICU management of acute coronary syndrome is, there is an overall decreased mortality. We used to see about 12 to 15% mortality earlier days when the ICU were introduced. And after that, we saw that now with a good treatment, it is somewhere around 5% to maximum 8%. And there is an cases are being discharged early, and risk stratification has become a more or less a norm in every hospital. And we are using liberally coronary angiogram and doing a PCI procedures. Not all the cases go for PCI, some medical, some even go for a CABG. And this is possible by looking at the extent of coronary artery disease. Low risk cases, there is an classification that is necessary by risk factors and risk modification. Low risk case, moderate risk case, high risk case, moderate high risk cases to take up angiogram, low risk cases, watch them, discharge them the same day, and ask them for OPD evaluation and the like. This will come by experience. These guys don't have any ECG abnormalities, enzymes may not be elevated, but the chest pain is ongoing. You can recognize very easily. The people are doing an early TMTs and early CT angiograms in some of these patients. And we should not forget about this, the unstable acute coronary syndrome, unstable angina, we do talk about it. Angina, that is ischemic syndrome, only we are talking. We should understand the patient is also unstable. And this particular thing is going through a phase of what is called the cool down time period, which is roughly a month period to 3 months period. And during that time, our treatment should be very aggressive. And then the follow-up should be done as for any secondary preventive therapy in a chronic stable IHD. We know that the major issues happen when they are in the first 1 week time, then the next 1 month period, then the next 1 year period. If these three periods are one over and they become what is called the chronic stable course, the prognosis is more or less equal to the same. So this is a final summary. If you make a possible disease, aspirin and evaluate. Probable disease, aspirin, clopidogrel, as I said in the beginning. For the PCI going patients, you can use other than the clopidogrel. You can take them for cath. Okay, use the cooling period as I said in the beginning. You can use. In this, I didn't mention much about GP2B3A inhibitors. They are also become very important drugs, and GP2B3 inhibitors are being used in the initial stage itself in some of the high risk cases like diabetes mellitus, and there have been ongoing chest pain. You expect previous MI and extensive anterior wall MI and the like. But some of the people do use it once they do the cath procedure. They make out the anatomy is not very suitable, very diffuse disease, very slow flow phenomena, or there is an thrombus burden is very high. In such cases, they are using, or in high risk population like diabetes and elderly, they are using it. I think with this I will try to end my talk. I have tried to cover up as much as possible how we should telescope both the evaluation and the treatment of acute coronary syndrome in the management of acute coronary syndrome. Any questions or doubtful, I'll be able to answer. Thank you for your patient hearing. Ankita, any questions or clarifications?
Yes, sir. Yes, sir. Sir, let me just take the questions one. Sir, the question is, how do you approach the management of patients with ACS who have comorbid conditions such as diabetes or CKD or heart failure?
So it doesn't anyway differ from the patient not having this and this thing. But the thing is, what I'm trying to bring in the point when the patients have diabetes or CKD and all of them, the risk of them dying in the ICU setup is quite high. Even if you do a procedure, the risk is high. Procedure risk also and the mortality risk also. We have to manage just like, for example, if the patient is a diabetic, we have to change them for intermittent insulin, preferably. Nowadays, we are using more of insulin infusions. If the patient is a CKD, we should be very careful. If the patient creatinine is already about 2 to 3 milligram percent and above, and urine output is low, we should not do an angiogram. We should do only conservative treatment. If the creatinine is of 1 to 1.2, we can take the help of here comes the multidisciplinary approach. We have to take the help of the nephrologist, okay, and they use all sorts of protective methods. But I have found out that the simple saline infusion before an angiogram is enough. That sort of a thing can be done. In a COPD patient, we have to see that they have a stable COPD or not, whether they have developed an RV infarction and along with the COPD with a possible right heart failure and the like. Is he dependent on oxygen earlier? And is he needing a bronchodilators, very high dose, frequent usage, because all of them are stimulants to the heart. Some of these things we should be interacting and keeping in mind with the other specialty doctors.
Right, sir. Thank you, sir. Thank you so much for giving us your precious time and putting up all these crystal thoughts into this webinar. Thank you so much. And I would like to thank all the audiences for joining in and for their active participation. Thank you so much, sir, once again for giving us your precious
Thank you
time.
very much. I am extremely sorry for the delay that happened.
No, sir. No, sir. No, sir. That
Thank
was
you.
not your fault. Thank you.
Okay.
Thank you so much, sir.
Goodbye.
Thank you, sir. Bye, sir.